Hi, I'm Hanna Tirado, Joint Care Coordinator here at Froedtert South. Today we're going to talk about your upcoming joint replacement surgery and go over some information that will help you prepare for your upcoming procedure. Hopefully this will answer any questions that you may have. If you come across any questions, feel free to give me a call. My contact number is at the bottom of the screen. So, I'm a nurse here at Froedtert South. I am working closely with you, so my job is to be your connection between your doctor's office and your surgery. So today we're going to discuss your upcoming procedure and help you answer any questions you may have. Total joint procedures that we talk about are total knee replacement, partial knee replacement, and total hip replacement. For these procedures, we're removing the damaged bone and cartilage from your joint, and we're inserting a artificial joint prosthesis. You have a guidebook that all of our patients do use. The guidebook has a tab for frequently asked questions, preoperative checklists that we have put together for you in chronological order, the best we could do to help you prepare for your surgery. Post-op goals and exercises. There's a section that goes through every exercise that we have you do in the hospital, and also we want you to start them before surgery. Discharge instructions and at-home resuming activities after surgery. So your guidebook takes you through your whole procedure. Optimizing yourself in preparation for surgery. You're going to see your primary care doctor 2 to 3 weeks before your surgical procedure. They are going to order testing. Lab work. Every single patient who comes through surgery has to get lab work done, so we will have you do some blood work. Also, some tests that may be performed before surgery: an EKG, chest x-ray. Not every single patient that comes through surgery has to have these done, but it is just to make sure that you are at optimal health and going through anesthesia. Sometimes we want you to have these done. So along with that EKG, sometimes we have you do a stress test. So it just depends on your health history and all those things. So your primary care doctor will determine which test is best for you. Any additional doctors you see, any doctor you see for your heart, liver, kidneys, any specialist you see, usually you have to call them or see them before you have this procedure done, just to make sure that you're at optimal health. Your doctor is going to go over your medications. The doctor who prescribes these medications for you will go over them and tell you which ones to start, which ones to stop, which medication should be continued up until the day of surgery. So normally it's the blood thinners that we're having you discontinue before surgery, but your surgeon, your primary doctor, will give you special instructions on blood thinners. Diabetic medication, you're going to be without eating and drinking for a few hours prior to surgery, and those diabetic medications normally are not taken the morning of surgery, but we will give you special instructions for those. Also, those NSAIDs, those non-steroidal anti-inflammatory drugs, those are the ones that are helping us for our joint pain. So those NSAIDs should be stopped 5 to 7 days prior to surgery. NSAIDs include ibuprofen, naproxen, Aleve, aspirin is an NSAID, should be stopped 5 to 7 days prior to surgery. Sometimes we have our stents in our hearts, and we continue taking aspirin as directed by our doctor, so that may be something that you stop or continue depending on your history. So those are all NSAIDs. We have a list of prescribed NSAIDs that we can include in this presentation. Celebrex is a common prescribed NSAID, should be stopped 5 to 7 days prior to surgery. Malaxicam or Mobic also is a common prescribed NSAID for joint pain, should also be stopped 5 to 7 days prior to surgery. So your physician who prescribes these will give you special instructions for those. Preparing for surgery, you're going to get a phone call from one of our pre-admission nurses. They're going to go over medications, health history, any surgery history. They want to know all that and want to make sure that that's up to date in your record. So when you come through surgery, that's all up to date and there's not so many questions asked. So they will give you a phone call the day before surgery. If your surgery is on a Monday, they will call you the Friday before. So just expect that phone call. It's up to you to maintain good health. Good hand washing. If you come in surgery day, coughing, sneezing, fever, doctor's going to tell you to go home, get better, and they'll reschedule your surgery. So nice, good hand washing helps prevent that cold. Prepare and freeze meals. You're going to go home to a kitchen you might not want to cook and stand over the stove for long periods of time, so we suggest you prepare and freeze meals prior to coming in for surgery. Home safety is important. We want you to go home to a nice, clean, safe home. Throw rugs, move them out of the way because they are tripping hazards. Make a nice, clear, wide path for walking. You may go home with some kind of assistive device, walker, or a cane. We want to make sure you can get through your home without tripping over any big coffee tables or anything. Checking placements of electrical cords. Those are also tripping hazards, so make sure the electrical cords are tucked away. Nice supportive shoe. We want you to come to the hospital with your nice tennis shoes on. You're going to be up and walking pretty quickly with therapy, so we want to make sure you have something supportive on your feet to walk around. Arrange for someone to care for pets. If you have pets at home, we want you to have your pets in a back bedroom or outside when you first come in the home. They're going to be excited to see you when you first come in. So we want to make sure that your pets are not jumping over you and knocking you over. Chair with armrests. You're going to rely a lot on your arms after surgery. So we want you to have a nice chair with armrests so you can get that bottom out of your chair. Consider having safety grab bars installed. Tub, toilet, shower areas are areas that grab bars are usually installed. Elevated commode seat shower chairs. These are pieces of equipment insurance usually does not cover bathroom equipment. So if you're thinking you want to get your hands on some bathroom equipment, Kenosha has wonderful loan closets, which our social worker will go over. Grooming items. Keeping your grooming items in your countertop in your bathroom. That way you're not bending down, slipping on a wet floor. Nice night light. Plug in a couple extra night lights. That way you can see your dog, cat laying in your path at night. Keeping your phone, cordless phone, cell phone in your pocket. You may be home a few hours by yourself. You go back to sit in that chair and you miss. You end up with your behind on the floor. You listened in class. You can pull out your cordless phone and call your family member, friend. They can help you up off the floor. Before surgery, you're going to follow your medications as instructed. Because you have me to look out what's going on in this community, I found we are probably the last place telling every single patient nothing to eat or drink after midnight. Well, I had a lovely meeting with our anesthesiologist and our surgeons, and our total joint patients have the latest, greatest anesthesia orders that say do not eat 6 hours prior to arrival, and you can continue drinking clear liquids, water, stopping 2 hours prior to arrival. No alcohol 24 hours prior to surgery. So you have a package of chlorhexidine wipes that your doctor has given you. You are going to do your chlorhexidine wipe down the night before surgery, and it only goes from your neck down to your toes. In your guidebook, page 15, there is a handout that goes over how to do your chlorhexidine wipe down. So that's in there. So it's going to be the night before surgery. You're going to shower, you're going to get out, dry off with a nice clean towel, and then you're going to do the wipes. They're already pre-moistened, so you're just going to wipe down from your neck down to your toes using all 6 of your pre-moistened wipes. Throw them all in the garbage after you're done. The day of your procedure, you're going to get another package of wipes when you get to the hospital, and those are going to be done before you get your surgical gown on. So 2 times, the night before surgery and then the morning at surgery, you'll do another wipe down. If you develop any redness, irritation, you should stop, rinse that off. You will have to use a different solution at the hospital. The chlorhexidine, same ingredient in your sterile prep. So when they do their sterile prep in surgery, that's a chlorhexidine solution. So if your body does not like that, the morning or the night before surgery, we want you to rinse that off and let your pre-surgery nurse know, because you'll have to use something else that morning. before surgery and in surgery. Day of surgery, what to bring is always a question. Sometimes we get those patients show up with like 3 suitcases full of stuff. Don't do that, that's too much stuff. Bare minimum. So we want you to bring a list of your medications. We're gonna give you your medications just like you take them at home. So we wanna know what medications you take at home and the last time you took them. That's gonna be important. Nice supportive shoe, bring your tennis shoes or wear them into the hospital. Loose fitting clothing. While you're in the hospital, you are going to get up and get dressed in your own clothing. So something loose fitting, something that's gonna be something you can work out and do your exercises with. Nothing too restricting. Personal care items, you're gonna pack an overnight bag and you're gonna put in all your lotions, moisturizers, makeup in that bag because we do not want anything on your skin before surgery. So you can put those on after surgery. CPAP, BiPAP machine, if you have sleep apnea and you sleep with a machine on at night, we want you to bring that to the pre-surgery area. Our biomed technician will have to check that in, make sure there's no frayed cords and then it's usable. And then when you wake up after surgery, sometimes they put that on. So your CPAP, BiPAP machine you can bring from home. Money, only money you need is if you don't have a family member or friend picking you up from the hospital. All of our transportation companies need money up front. So that's the only time you would need money at the hospital. Walker, cane, if you need a walker or cane to get in the building, of course, bring it with you. But if you don't need your walker or cane to come in, leave it in the backseat of the car. You will use our equipment when you're in the hospital. You will use our walkers, you will use our canes. Sometimes crutches are preferred after surgery. So we have all that equipment here for you to use. So if you have your own equipment that you're bringing with you because you need it to get in the building, we will have you label it with your name on it. Guidebook. You are going to accumulate a lot of paperwork. So that guidebook, you're going to have a good spot to keep it all together. Papers, any discharge instructions you can throw in that guidebook. Valuables, do not bring your valuables. Leave your diamonds, emeralds, pearls at home. We don't want to be responsible for those. Medications, we will give you medications from our pharmacy. We will charge your insurance company for them because you're only going to be in the hospital for 1 to 2 nights. We will provide your medications while you're in the hospital. We do not want everybody to bring their medications from home, so leave those at home. What I tell you to bring, our pre-surgery nurses don't love that I tell you this, but I do because you're only here for 1 to 2 nights. We want you to bring anything that's multi-dose, an inhaler, medicated creams, eye drops, anything that you already have a month supply of, we want you to bring from home. That way you can use your own medications and not have to purchase another month's supply. However, we do not have any medications at our bedside, so your pre-surgery nurse will take that from you. They'll write a little note, send it down to the pharmacy. Pharmacist will verify it, make sure it's not expired, that it's usable, and they will send it up to your room that you will be in after surgery. There's a little locked drawer. They will lock it all away. That way, when you need your eye drops or your inhaler, your nurse can unlock your drawer and give you your own medication. If you forget and you don't bring your inhaler, that's okay. We will provide that for you. It comes from our pharmacy, and if there's any extras, they will send that home with you. So they will send your own medication and your extra doses of inhaler home with you. Day of surgery, it's important to arrive on time. Your nurse is going to review your health history, medication history. They're going to start your IV and prepare you for your procedure. Where to report? You're going to come to the Pleasant Prairie Outpatient Surgery Center. That has its own entrance. It is labeled Outpatient Surgery Center, and there's a covered garage. That's where you will come the morning of surgery. You're going to check in with the surgery hostess. You are going to meet your anesthesiologist the morning of surgery. Also, your surgeon will be there the morning of surgery. They're going to discuss any health medication history that you have. They're going to discuss any nausea and pain management they're going to put in play for you. General anesthesia is usually given while you're under general anesthesia. They're going to give you some sedation. You may wake up. Mild sore throat is common after surgery, so what we usually suggest is that you pack in that overnight bag some throat lozenges, hard candy, something to help with that sore throat after surgery. If you're having knee surgery, you're going to meet your anesthesiologist and they're going to bring you into the recovery room prior to surgery. They are going to give you this wonderful drug called Versed. After that, you won't care what's going on, but they're going to do that nerve block. The nerve block is done in your leg to help with pain after surgery. They do this nerve block before you even go back to the OR because that's a large nerve and it takes a long time for that nerve block to set up. It is an injection of some lidocaine, xylocaine, something that your anesthesiologist will talk to you about before they do the procedure. That nerve block sometimes causes some muscle weakness, up to 24 hours. So we will remind you the first time you get up, that leg might be a little more weak, but we'll remind you that it's because of that nerve block and that's that pain, it's helping with pain in that knee. So that's the nerve block. We always numb the nerve that's above the joint. So for our hip patients, usually we give you a little spinal anesthetic, but that's done in the operating room. So if you wake up after surgery, legs feel a little heavy, that's all normal. Usually that lasts about an hour after surgery. Sometimes our knee patients get a spinal anesthetic as well, but your anesthesiologist will discuss that with you. You'll be in the recovery room for 1 to 2 hours after surgery. Your nurse will monitor your vital signs, assess any pain you have, and they're going to be asking you to rate your pain. 0 being no pain, 10 being the worst possible pain you can ever have. We want you to rate your pain according to what you feel. Sometimes we have a little trouble rating our pain and we will go over that and we'll kind of guide you through it. The reason why we want you to rate your pain is because your surgeon has your pain medication ordered based on your pain scale. So if you tell your nurse your pain's a 5, 6, guess what? You're getting the lower dose of pain medication. If you tell your nurse your pain's a 9, 10, you'll get a higher dose of medication. So we want you to rate your pain appropriately. If you tell your nurse your pain's a 20, we don't know that number. That's not on the pain scale. No, that means you waited too long, and we'll do this. You waited too long. It's important to rate your pain appropriately. In different types of discomfort, incision pain, soreness, pressure, we treat with pain medication. It's going to be that burning, that incision pain that you feel after surgery. That deep bone pain, usually gone after surgery. It's that burning of the incision. Swelling, bruising, tightness around the joint, we're going to treat with some ice, elevation. Icing is going to be very important after surgery. Icing is going to help with pain, so we want you to ice, ice, ice. Helps with swelling and pain. It's your responsibility to ask for your pain medication. Like I said, don't wait until it gets to that large number. We want you to take your pain medication at a regular basis, on a regular basis. Additional comfort measures is that ice, that cold therapy, position changes. Believe it or not, walking around, moving that joint actually helps with pain. We hear time and time again that it helps getting that walk in before you lay down at night. Preventing post-op complications, this is where I have to tell you the bad things that could happen. We're trying to prevent infection. We're going to monitor your vital signs, inspect your incision, antibiotics. We're going to give you a few doses of antibiotic just to kind of ward off those evil little germs that got in your bloodstream. Nausea, vomiting, we blame anesthesia. Well, not really. Pain medication sometimes causes that. Nausea, vomiting to happen after surgery. We have a medication goes right in your IV for that. Constipation, same thing. Anesthesia slows things down. Pain medication slows things down. We want to prevent constipation as much as we can, so we're going to give you a stool softener that next morning after surgery. Frequent walking, diet, we tell you to drink, drink, drink lots of fluids after surgery to help prevent constipation. Blood clots in those legs and lungs, we're trying to prevent as well. Those TED hose stockings, some of our doctors use those white tight TED hose stockings on your legs. You will have those on after surgery if your doctor uses them. If they don't use them, then you will not even have those TED hose stockings on. Those SCD machines, kind of like a blood pressure cuff, inflating, deflating around those lower legs to help your circulation in your legs. Ankle pumps, just pumping your ankles back and forth, helps prevent blood clots in your legs. coagulant medication. So after surgery, it's important to listen to what your doctor prescribes. A lot of times they're prescribing a 325 milligram aspirin after surgery. It's going to help prevent blood clots in your legs and lungs. It's going to help keep your blood slippery. If you've already been on a blood thinner and that was stopped before surgery, you're going to resume that blood thinner. We're going to continue that blood thinner. Usually it's started that night after surgery or that next day. But your doctors will prescribe that if that's what you were on. Pneumonia, we're going to give you this nice incentive spirometer, tell you to take nice deep breaths, do some coughing exercises, keep those bases of your lungs open to prevent pneumonia. Role of your coach. So now we have your coach involved. It's a family member, friend, someone that's going to be there for you to provide comfort, motivation, assist with driving you around. You might need somebody to drive you to therapy. Back. You may not be driving for 2 to 3 weeks after surgery, so you might need a coach for that. Help you with those TED hose stockings, observe therapy sessions, so that's your coach. While you're in the hospital, you're going to get a daily newsletter. It's going to tell you what to expect for the day. It's going to give you daily plan. So you're going to wake up usually around 6 a.m. in the morning. You're going to have some breakfast around 7:30. Then your therapist is going to be there bright and early, and they're going to do some exercises with you. You're going to do some individual therapy and some group therapy. If you have group therapy, you're going to walk down the hall to our group therapy department where you will have other joint patients with you. And we'll do some group therapy in the morning. We'll have some lunch around 11:30 and then some more group therapy in the afternoon. Then, if you're still around in the evening, dinner is usually served around 5:30. We do another walk around before you lay down for the night. So we keep you pretty busy during the day, and that's good. That helps with that joint. So transition home. We're making that discharge plan. Your home assessment. Everybody's working together. Your social worker, physical therapist, occupational therapist, surgeon, nursing staff. Everybody's working together to get you home safely. Okay, so now we're going to hear a few words from Kelly, our social worker, and she's going to give you some information about discharge planning and getting your hands on some equipment.
Hi, I'm Kelly. I'm one of the social workers. Everyone that comes in for surgery automatically meets with a social worker. We go through all the discharge planning with you. So we're the ones setting up services for whether you're able to go home or may need a short-term rehab stay. I'm going to talk primarily about what Medicare covers. So if any of you do have a private insurance as primary, I would encourage you to contact your insurance company before your surgery just to kind of see what benefits you might be eligible for. So the first day you'll come in for surgery, second day you'll have therapy both in the morning and afternoon. We tend to meet with you after your first session of therapy just to kind of see how you're moving around. Rehab options, there are 3. One is going home and doing outpatient physical therapy. Second option is going home and having someone come to the house to do therapy. Third option is our inpatient rehab, which is located in the local nursing homes. So if you are able to go home and have the support that you need, what happens is the doctor will write you a prescription. It will be up to you to schedule your own outpatient physical therapy appointments. Medicare will basically cover wherever you want to go. So if you do want to come back here, or if there's a place really close to home, that's completely up to you. It says we ask that you set up your own therapy appointments. We also make sure that you have transportation arranged back and forth from therapy. If you are able to go home, but it might be very difficult to get in and out of a vehicle, there are agencies called visiting nurses. These people come to your home. They will do the home therapy, any blood draws if needed, and any dressing changes if needed. Medicare will cover the service at 100%. However, you do have to be homebound. Homebound means it's very taxing or very difficult for you to leave your house. Medicare will allow you to go to your outpatient doctor appointments. If you are a churchgoer, you are allowed to go to church. Outside of that, you're strictly stuck at home. Most people that do the in-home therapy are usually homebound 1 to 2 weeks. Afterwards, if you need to continue to do your therapy, Medicare will allow you to go as an outpatient to complete your therapy. Third option is our inpatient rehab. Those are located in the nursing homes. We have 8 nursing homes in Kenosha. All of them have short-term rehab. Medicare will cover the first 20 days at 100%, and then from day 21 to day 100, Medicare's covered at 80%. If you have a supplement, they should pick up the remaining 20%. Again, most people that are looking to go to a nursing home are probably there for 1 to 2 weeks. If any of you are considering going to a nursing home and maybe don't know where you'd like to go, I would encourage you to go out and tour the facilities before your surgery. I usually tell people do not make phone calls before you go. If you show up unexpectedly, it's going to give you a better picture of what's going on at the nursing homes. Medicare.gov is also a very good website. It will give you a 5-star rating on all the facilities in Kenosha. Equipment, Medicare will cover one piece of equipment at 80%. If you have a supplement, they should pick up the remaining 20%. Those items include your canes and walkers. If anyone is looking to get a raised toilet seat or a shower bench, Medicare will not cover any type of bathroom equipment. Walgreens, Menards, Lowe's, Meijers, they do sell them at a pretty reasonable cost. We do have 2 loan closets in Kenosha. One is at the Department of Aging, the other is at St. Peter's Church. You can always call ahead, put whatever items you want on hold, you go pick it up, it's free of charge. They just ask that you return it when you're finished with it. And then just a quick thing on transportation, obviously friends and family can transport you home. If you are considering needing a wheelchair transport, Caravan is our cheapest wheelchair ride. It runs $4. However, they do ask that you have the money up front. If there are any questions, people can call me directly. My direct phone number is 262-653-5231. Thanks.
And now here to talk about spiritual care services is Chaplain David.
My name is David Bauer, and I'm one of the chaplains with the spiritual care department here. Just want you to know that we're here to serve you while you're here having your surgery. We do serve people of all faiths and people who don't have a faith. We're just a part of the team. You'll see chaplains in the inpatient and outpatient service areas. You will be asked some questions upon admission. You'll be asked about your spirituality because we want to make sure that we're taking care of you body, mind, and spirit. So they'll ask some questions just concerning if you have a faith tradition, if you'd like your place of worship contacted, and if you'd like to see a chaplain. So again, those are some basic questions that you'll be asked. Those will help us to know how we can serve you the best while you're here. You'll also be asked about advance directives, either the documents that we have here. We do help out with social services completing those advance directives. We do recommend that everybody over 18 has them in place. So our chaplains are here Monday through Friday between about 9 and probably 3:30 on the floors. So if there's something that you need after that, we do have full-time staff that is there after, and they are a part of our on-call team. So again, that's another way that we can serve you. Again, thank you for allowing us to serve you, and blessings with your surgery.
One of our dietitians, Amy, is here to talk about joint replacement and healthy eating.
Hi, my name is Amy. I'm one of the dietitians here at Froedtert South. I'm here to talk to you today about the importance of nutrition in your recovery from your joint surgery. So we talk about healthy eating during surgery because we feel it's very important that you choose the right foods to help your recovery process. In choosing the right foods, you can increase your healing time, you can decrease any unwanted weight gain, and you can also improve your health overall if you have any chronic conditions that require a nutritional strategy for the treatment of the problem. Let's define healthy eating. The Academy of Nutrition and Dietetics defines healthy eating as choosing foods that are low in sodium, low in fat, low in added sugar, and high in fiber. What does that mean with regards to eating food? That means eating more fruits and vegetables, eating more whole grains, eating lean meats and proteins, eating dried beans, and more unsaturated fats than saturated fats. And it means eating less of everything else. In the handout that you have for home, we put a lot of information together for you regarding healthy eating. One of the easiest ways to determine whether a food is healthy or not is to check the food label. The food label has a lot of information regarding the foods that you're eating. I'm going to highlight the most important things for you to pay attention to for your healing process. The first thing to look at is serving size, which is usually found towards the top of the food label on the package of the food that you're eating. It's very important to look at serving size because my idea of a portion and the box's idea of a portion oftentimes don't see eye to eye. So all of the nutrition information that you see on a food label is with regard to the one serving. If you eat 2 times the serving, all of the nutrition information on the food label also doubles. If you eat half a serving, all the nutrition information on the food label is cut in half. So that's why it's very important to pay attention to the portion size that's posted on the food label. An example I like to give everyone in class is I take a bottle of Coke, a 20-ounce bottle of Coke. If you flip it over and look at the food label and it says 150 calories, but you fail to look at the serving size, you will think that the entire bottle is 150 calories. In fact, the serving size is a half a bottle of Coke. So if you drink the whole bottle of Coke, you're drinking 2 servings, which is 300 calories instead of 150. So that's where it's really important to pay attention to those portion sizes. The next thing I like you to look at is fat. Not total fat, but saturated fat and trans fat. So the current research is showing that saturated fat and trans fat are what we call bad fats. Okay, we call them bad fats because they will increase your cholesterol levels and they can contribute to heart problems. The goal is for you to eat less saturated fat and less trans fat. Now, which foods are high in saturated fat? Those foods are typically high-fat dairy and high-fat meat products. Your food label will tell you how much saturated fat is in a food per serving. The goal amount you want to keep under is 15 grams per day. Trans fat is found in a lot of processed foods. Foods such as margarine, foods such as processed desserts like frostings, Oreos used to contain trans fats. And what they're finding is that trans fats are just as bad as saturated fat. So you want to keep those levels as close to 0 as possible. The next thing you want to look at is sodium on the food label. Sodium is measured in milligrams, and a low sodium food will contain 200 milligrams or less per serving of sodium. Foods that are high in sodium include processed foods mostly, like canned soups, canned vegetables, processed meats like lunch meat, bacon, sausage, ham, and the list really goes on because the more processed a food is, the higher it is in sodium. Sodium is not good for our bodies because it can contribute to problems with blood pressure. It can contribute to problems of the kidney and of the liver and of the heart. So it's very important that we limit our sodium intake to less than 2,000 milligrams per day. 2,000 milligrams sounds like a lot, but 1 can of Campbell's chicken noodle soup will contain more than your daily allotment for sodium. So it's really important for you to pay attention to the food labels, especially for sodium. The next item that we like you to look at on the food label is fiber. Now, fiber is something that we like you to eat a lot of because it can help with blood sugar control if you're diabetic. It can help with weight management if you're trying to lose weight. It can help with cholesterol levels if you have high cholesterol. And last but not least, it does help keeping regular bowel movements. And since you're going for surgery and you're likely going to be having pain medications as part of your medication regimen, it's really important that you keep those bowels moving, and fiber will help you do that. If you're reading food labels, high fiber foods will be designated as 3 grams or more per serving. And fiber is found in mostly fruits and vegetables, found in whole grains and dry beans. Fiber is also found in whole grain breads, whole grain cereals such as oatmeal or Cheerios or shredded wheat. There's lots of places to find fiber in the diet, so we encourage you to eat as much as possible. If you don't eat a lot of fiber at home currently, you will want to gradually increase the amount of fiber in your diet, because if you go from no fiber to a whole bunch of fiber, you may experience some gas or some abdominal cramping because your body's not used to having all of this fiber. The last item we like you to look at on the food label is added sugars. The new food label delineates between added sugar and natural occurring sugar. The difference between the two is that added sugar is what we want you to eat less of in your diet. Naturally occurring sugar is not considered unhealthy, so we don't ask you to limit naturally occurring sugars that are found in fruit or in dairy products. It's the added sugar that seems to be a problem. Added sugar you want to try to keep to less than 20 grams per day, but that number adds up rather quickly as well, because as you will see from reading food labels, they do add sugar to a lot of things. Things that you would never guess sugar is added to, such as salad dressing and biscuits and pancake mixes. All sorts of products will have added sugar that you didn't even know was there, especially if you're not reading the food label. On the back of the handout that you have at home, you will see a list of foods that we consider healthy. It is not by any means an all-inclusive list, but it does go through every food group and gives you a column of foods that we recommend that are healthy, and a column of foods that are less healthy on the opposite side. So that list is really helpful for people who don't want to read the food label, really helpful for folks who are just looking for a list and they don't want to think too much about what to eat and what not to eat by reading a food label. So I encourage you to use that if you have any desire to. Last but not least, I want to talk to you a little bit about your hospital stay and what to expect from the nutrition and food service team. Nutrition is not an automatic consult when you get to the hospital. We will see you if the doctor consults us to come see you. So if you have any desire to be seen by the dietitian, it's important that you communicate that with your nurse or with your doctor, and they will ask us to come visit and give you any information or education that you may need. Secondly, you'll see the dietitian if your appetite is not great after surgery. If you happen to be staying more than a day or two and your appetite has not yet returned to normal, the nurse is going to be asking us to see you. The reason for that is a day or two after surgery, we give you a pass on not eating well or not feeling well, or even not tolerating food well. After a couple of days, that's when the importance of nutrition intake is going to start affecting your healing. So we need you to eat protein-rich foods. We need you to eat the vegetables and proteins at least 3 times a day. And that will help with the healing process. It'll help with blood sugar control. It'll help with keeping your bowels moving regular. But most importantly, it's going to help with that healing process. And if you're not eating well, you're not healing well. So we really want to make sure that you're eating well enough after surgery. And if you're not, consider adding an Ensure type of protein drink to help with the healing process. Third, if you're staying at the hospital for any amount of time, I want to educate you on the food service. Our dining program is called room service. When you get to your room, you will receive a menu. The menu is what you will use to order for the entire stay. On the menu, when you open it up, you will see that there are instructions on how to order, but basically, you got to call the kitchen in order to get your food. If you don't call the kitchen, food will not show up. So it's very important that you look at your menu and call the kitchen and tell them what you want. If you are on a restricted diet of any kind, whether that be carbohydrate restriction, sodium restriction, or fat restriction, those all will be accounted for when you call the kitchen and order your food. The menu is also coded for several health conditions. It's coded for carbohydrate content, it's coded for fat and sodium content of foods. If you need a gluten-free diet, it's coded for gluten-free items as well. And that's all that I have for you today. Please feel free to contact myself or anyone on our team anytime. Thank you and good luck with your recovery.
Now we have Peggy to give a little demonstration on some exercises and what to expect while you're in the hospital with physical therapy.
Hi, I'm Peggy. I'm a physical therapist here at Froedtert South. I'm here today to talk a little bit about what you can expect with physical therapy with the Total Joint Hip and Knee program. I know that you have a handout, and the handout that I will be starting to talk on has rehabilitation on top. Before I get to that, however, I do like to mention, as I've talked in classes before, that social work has brought up a plan or discussed what is your plan once you leave the hospital. I'd like you to bring this up is because I would like you to talk with your surgeon about that so you have something in mind when you leave the hospital. The social work talked about the nursing home. That's not used as commonly as it was in the past. There's also home health therapy and there's outpatient therapy. With the home health therapy, it's nice because the therapist comes into your home. However, with that, what tends to happen is the insurance wants you homebound if you're going to be having this type of service. With outpatient therapy, this is where you actually go to the clinic for your therapy. That has its benefits in the fact that you can see the therapist, there's the different equipment that you can use, and so they can challenge you in different ways that they can't challenge you in home. The issue that comes with that is initially the surgeon has you where you cannot drive. You need to get a surgeon's release to be able to drive again. So if that's the case, you need to have someone to give you a ride to the facility. So there again, there's the 3 different choices. I'd like you to start thinking about those choices. If you end up going with short-term rehab or more commonly the home health therapy, the social work will help set that up when you're here at the hospital. With outpatient therapy, you're going to need to set that up, well, especially now that we're having to do the video because of the COVID-19, you will be needing to set that up on your own. If you're interested in one of our facilities, I know that you've gotten the guidebook. With the guidebook, whether it's the hip or knee guidebook, we have all of our facilities on that last page of the book. So you'll have the addresses and the phone numbers and that type of thing. So we ask you to give them a call and tell them that you're having a surgery, the date of the surgery, and to make an appointment for the initial evaluation about 3 days out. Our typical stay here at the hospital is only 1 or 2 days, but we have you do 3 days for the buffer. Now with the COVID-19, we do have some closing of the clinics. 2 of the primary clinics are still open. It's the Prairie Ridge, which is right behind the Pleasant Prairie Hospital, and the Summers Clinic that's out by Walmart and Target, or Walmart and Sam's Club on Green Bay Road. Okay. Now, that being said, so what we want you to do is go ahead, give that a call. I've heard, as far as when I see patients here at the hospital, one of the issues they might come in if they end up calling a different clinic outside of our Froedtert South is that they need a prescription. Tell them not to worry. The surgeon will write up a prescription because it's required with our program that you have some therapy after you leave the hospital. So, all right, I think we can finally get to the slide that has rehabilitation on top, and we're going to be talking about physical therapy here at the hospital. It's not unusual for you to have surgery bright and early in the morning, and after the surgery you go into recovery. From recovery you get admitted to the hospital room. Now, there is a little different situation going on now with the change of Medicare requirements in that there are people that will be having same-day surgery. So when I'm going through this, some of this will apply to you. Obviously, certain things will not apply to you. Later on, we'll be talking about group therapy, that type of thing. You won't be doing group therapy. What happens is we will be seeing you in the outpatient surgical center, doing evaluation, making sure you're safe, going over some of the exercises with you, and that's where it's crucial for you to have that outpatient therapy or home health therapy set up, because you will be actually working on that the next day or 2 after leaving, having that same day surgery. So these are for the patients that actually are going to be coming to the hospital room. Don't be surprised if you see our happy, sun-shining little faces that same day of surgery. I've actually walked into the room and people have said, "Oh my gosh, you weren't kidding, you are here." So don't be surprised if you see us that same day of surgery. If for some reason the surgeries are running late and you don't get into the room until later on in the evening, no worries. What happens is the nursing staff will get you up and we'll see you first thing in the morning. Occupational therapy, it's not unusual for them to see you first thing in the morning. We'll be asking you questions about your home environment and also your previous level of function. Basically, common questions about your home environment. How many steps or stairs are there to get into the house? Is there a railing on the right side or the left side as you enter? Some people will tell me they have railings on both sides, and then my next question is, are you able to reach them same time, or are they too far apart? Once you're in the home, are you able to stay on that main level, or do you have to get to an upper or lower level bedroom or bathroom? And then again, if you need to, how many steps or stairs to get up to that floor? What side's the railing? Occupational therapy works with things they call activities of daily living. So this is where they want to make sure that you're able to get yourself dressed, on and off the toilet, in and out of the shower. So typical questions that they'd be asking, do you have the standard height toilet, or do you have that slightly elevated toilet seat? Do you have walk-in shower or tub shower? They'll also ask about grab bars. Do you have a grab bar by the shower that you can hold on to when you're getting in and out? Towel bars don't count because those can rip out of the wall, so you want a nice strong bar to hold on to. So those are just some of the common questions we'll be asking about the home environment. As far as the previous level and function, basically what we're wondering about is, are you using a walker or a cane prior to coming in or prior to your surgery? Also, have you had any falls in the last 6 months? So those are the typical questions we ask for previous level of function. So now I'm going to talk a little bit. Group therapy is twice a day. It's once in the morning, once in the afternoon. This runs on Tuesday through Friday. We're seeing you one time a day on weekends and like holidays and that type of thing. With the COVID crisis going on right now, we're not doing group therapy. With that, we're seeing people individually, and I'll be talking about individually, and I'll go more into group later. So with your individual physical therapy, I'm going to have you go to your next slide on your sheet. It talks about the evaluation. I bring it to the evaluation because this is what we're looking at the eval, and this is what we work on in individual therapy. So I mentioned we're going to see you the day of surgery, unless it's running a little bit later. In that case, we'll see you early the next morning. We want to take a look at and see if you're able to get in and out of bed. We want to see how you're getting and standing up and sitting down in chairs, walking with an assistive device. There's a picture on your slide that shows a person walking with a two-wheeled walker. This is what we commonly start people with. Some may progress to a cane, some might progress to a walker. A cane or crutches. It all depends on what the patient's needs are and making sure that they're safe. On that slide, it also shows the person has the little slippers, those grippy sock slippers. You'll be getting those here at the hospital. However, the surgeons like you to walk in a nice supportive shoe. So we ask you to bring a nice supportive shoe in. Now, some patients get smart on me and they say, I don't want to have to mess around with tying my shoes, so I'm going to get the slip-on shoes. That's a good idea. We ask, however, if you're going to do a slide-on shoe, one is that they don't flip-flop, because if they flip-flop, that puts you at risk for falls. The other thing is I want you to think about when you're doing that is if the shoes are snug prior to surgery, after surgery, what happens, there tends to be swelling in the feet, and they can be a dickens to get on. So I've had some patients that haven't even been able to get those shoes on. So if you're bringing those slip-on shoes or any shoe, you just want to make sure there's some breathing room in those. Okay. Now the other thing is it talks about exercises a little bit on the slide, but we'll talk about the exercises more when we get to group. And then we progress to steps and stairs. That's where we're referring back to what is your home environment, because our goal is we want to make you safe so you're able to go home safely. Occupational therapy is the next slide there. I am not an occupational therapist, so I'm just going to touch on this briefly. As I said before, is they're doing activities of daily living, so they want to make sure you're able to get dressed, on and off the toilet, in and out of the shower, that type of thing. Some people may struggle with getting themselves dressed or some of the activities, so they have equipment that they call assistive devices. With the assistive devices, they have like the things like the little reacher. I think everybody's seen that with the little gripper, that type of thing. They have a sock aid, which is a picture in your handout. And so what happens is occupational therapy, when they do their evaluation, they'll assess and see how you're dressing and how you're able to do these things, if you may benefit from these assistive devices, and if you're interested, they can issue those right here on site. So again, I'll let them talk more about that. The next slide is total joint precautions after surgery. We used to talk about the joint precautions, and then what would happen is we had multiple people sitting in the room. One person would be having a knee surgery, another person would be having a hip surgery. That person would have this surgeon with a different approach from the other person across the room, which had a different approach. So what would happen is that there was this muddling of all these different precautions. So what we decided to do is just encourage you to talk to your surgeon and find out specifically what your precautions are. We put the precautions also in the guidebook, and no worries, when you're here at the hospital, we'll know exactly what procedure you've had, what precautions you have, and we will be glad to educate you on those while you're here at the hospital. So that brings us to our next slide, which talks about the exercises. These are the exercises that we'll be doing in group. We do it twice a day. Again, those run Tuesday to Friday, and with the COVID crisis, we will be doing the exercises individually with you in your room. It's twice a day except on the weekends, holidays, that type of thing. And then when you go home, we have you do it for your home program. If you're real astute, you'll see on the top of the slide it says preoperative exercise. So yes, we do want you to start these exercises now after this class. We're asking you to do them once a day, every day, until your surgery starts. This is so important because it really helps to prepare you for the surgery. The more mobile and stronger you are prior to surgery, the better you do after surgery. And we see this with patients. When they come in, I can tell when they've been really dedicated to doing these exercises. So I'm going to come to my bed, and we're going to demonstrate these exercises. We're on to the preoperative exercises, and as I mentioned, we want you to get these started right away. So if you go in your guidebook, it's the second to the last tab. It says Therapy and Exercises, and all the exercises we're going over today, it has the list and pictures of the exercises and explanation. So again, that's the Therapy and Exercise tab. So I'm going to run through these. And at first, it's like, oh my gosh, 13 exercises is going to take forever, but they actually go pretty quick. So the first one is the long arc quad. And what I'm going to do is slide this up. This is going to be my surgical leg. I've had patients in the past that have asked me during class, do we just do this with the surgical leg or do we do it with both legs? And what I tell people is, especially patients that are having knee surgery, it's not unusual for them to be coming and having the other one done also. So absolutely, go ahead and do the exercises with both legs. However, due to time constraints at the hospital, we focus on the surgical leg. So I'm going to focus on the surgical leg. The first one is called long arc quads. The person sitting in the chair, and all you're doing is sitting back so the thigh is nice and supported, kicking that leg up and coming down. So kicking up and coming down. Just nice, slow, and controlled. In the book, for each of the exercises, it says to do 10 repetitions for 2 sets. So we're asking you to do 10 repetitions in 2 sets. I had another gentleman that when I was working with, he had mentioned that he was doing preoperative therapy, and on some of the harder exercises, he could only do 10 of those. My response to him is 10 is better than none, so do what you can. So if you're struggling a little bit, but you can do the 10, the 15, do the 10, 15. If any of these exercises cause you to have a lot of pain, it inflames that joint, and you're having problems with it, don't do that exercise. Our intention is to get you prepared for the surgery. We're not trying to get you inflamed and sore. So if you're struggling with any of these exercises, stop doing that exercise and focus on the rest. Okay? Now, the next 2 through 8 are done in bed. So this is my bed. We don't want you on the floor. We don't want you across your chaise lounge at home. So these are your bed exercises. Number 2 is called heel slide. So I'm going to bend my opposite leg up, and what you're doing then is you're sliding the heel up on the surgical leg and sliding down. Sliding it up and down. And you can see where that's going to just mobilize that hip and knee. You won't have your shoes on in bed, so it'll probably slide a lot easier for you. That takes us to number 3. Number 3 is called hip AB adduction, which sounds really fancy, but all it really is sliding the leg out to the side and back. Sliding out to the side and back. The key with this exercise is the knee and the toe continue to point straight up towards the sky. So you're sliding the leg out this way, not rolling it out that way. Okay? For some people with the hip pain, you might be having a smaller range, which is absolutely fine. So you just slide the leg out and back. In class, I'll call this like the one-legged snow angel. I've heard other people call it the windshield wiper exercise. Number 4 is the quad set. With the quad set, these are your quadricep muscles. And what you're doing with that is you're pushing that knee down for the count of 5. 1, 2, 3, 4, 5, and release. Push. 2, 2, 3, 4, 5, release. Push. 3, 2, 3, 4, 5, release. So with this one, you're doing it for a count of 5, and the main thing with that is you don't want to hold your breath. So what I've told people in the past is that you just count your numbers out loud. And some people don't like the way I count crazy. So what you can do is push 1, 2, 3, 4, 5. 2, 2, oh, shoot. 1, 2, 3, 4, 5. I'm sorry, I've got that habit of counting. 1, 2, 3, 4, 5. Okay. Next, number 5 is the straight leg raise. I'm laying back, you're kind of propped, semi-reclined. You can put some pillows behind you. With this exercise, there's a couple key things that you want to do to make sure you perform it correctly. One is you bend up the opposite leg's knee. You want to do this because that's going to stabilize the pelvis to support your back. So make sure that opposite leg is bent up. Then with the surgical leg, you're going to do that quad set, what we just did. It's like your warm-up for this exercise. You're going to push that knee down. You're going to pull the toe to the nose and lock that leg and lift. Okay? So push the knee down, pull the toes to nose, lock and lift. And I'll have people say, how high should I lift it? You don't have to lift it really high. You don't even have to pass this knee. What your focus is to get that leg locked nice and straight and lift it up and controlled down. Okay. Next is the ankle pumps. That's where you're just pumping the feet up and down. It's like a gas pedal. This one's nice and easy. We do that last one is one of our harder exercises. So we do a nice easy one after it. When you're here at the hospital, I'll tell people you can't do too many of the ankle pumps. That keeps your circulation going, keeps those calves nice and soft and pliable, and it helps keep that pain down. So you want to do those throughout your waking hour. Next, number 7 is short arc quad. In the book, you'll notice that the person has an exercise roll underneath the leg. What we ask you to do, I've got one of our program towels here, is we have you take a bath towel, fold it up, roll it on up, and voila, there's your exercise roll. So we'll slide that right underneath. It's a little slightly higher. And then what you're doing with this is you're just straightening that leg up and coming down. So straighten up and down. So it's like a little end range kick as you're just kicking up, down. And you want to make sure that that thigh stays on the roll. You don't want to be lifting that off the roll. It's just an end squeeze, end squeeze. Then the last bat exercise is called gluteal sets. That's fancy for butt squeeze. You want to squeeze the butt cheeks together for the count of 5 and release. Squeeze, 1, 2, 3, 4, 5, release. And yes, we put it as a bed exercise, but you could do it in sitting. But again, with this one, it's the hold of 5, and we don't want you to hold your breath. That moves to number 9, 10, and 11, our standing exercises. In the book, it shows the person holding on to a chair. Unfortunately, we couldn't manipulate those pictures, and we wrote in there, but I like to point it out. We want you to hold on to a sink or a nice stable surface. Because if you're holding on to a chair, what happens if you start to fall backwards is that will just start to fall back with you. So we don't want you to do that. So I'm going to come over to the bar over here, and that will be your sink or your counter that you'll be holding on to at home. Okay? Okay, so with the standing exercises, you want to be at that counter. Personally, I like the sink because I can hook my fingers in. You're going to stand with your feet shoulder width apart, and the first standing exercise is the heel raise. So you're lifting the heels up and coming foot flat. Heels up, foot flat. Heels up, foot flat. Then the next one is the mini squat. The main thing with the mini squat is I'll see people in the class come in and they start squatting and they come straight down. So their knees are coming forward. You don't want to do that. That's hard on your knees. Even if you're having the hip surgery, we don't want you to start having knee problems. So stand pretty close to the counter, and what you're going to do is stick that butt back and down to get the knees to bend. So it's like you fold at the hip to get the knees to bend. So you're coming back and down, chest stays up, back and down, and you don't have to go real low. These are mini squats, so just right here, right there, right there. I had a lady that was a skier, and she said, it's like my ski position, and I thought, oh, I like that, so I stole it from her. The last standing is called with the knee flexion. You're going to stand in like a diagonal stance. So on your non-surgical leg, and you have the surgical leg slightly behind you, you're going to bend the knee up and tap the toe down. Bend the knee up and tap the toe down. With this exercise, this is our cool down stretch. So that muscles, remember the quadriceps where we were pushing down, we're pushing with it, we're kicking with it. So this muscle, what we want to do is have it calm down so it doesn't spasm up on us. So just nice and gentle, you're going to bend that knee up and come down. It's almost like going into it, like you're working taffy or dough, that type of thing. So just nice and soft, work with the muscle, not against it. You don't want to fight it. So nice and easy, coming up and down, up and down. So those are the 3 standing exercises. We just have the 2 other exercises that we do in sitting again. So I'm going to come back to the chair and show you the sitting exercises. The last 2 exercises, we're back to the chair, and number 12 says armchair push-up. This is one exercise we don't have you do after the surgery. Basically, it's to prepare you for the surgery. Because when you're here at the hospital and at home, you're using your arms to scoot out of bed, to stand up properly from the chair, and this is what we'll be asking you to do is you push off, you take a hold of the walker, you're pushing down on that walker, and then to do a controlled sit is we have you reach back and you lower yourself. So you're using those arms quite a bit to help support that surgical leg. So what we have you doing is you scoot halfway forward in the armchair, you're putting your arms right here. All you're doing is lifting the butt up and coming down. So lifting up and down. And again, we don't have you doing this after surgery, it's just to help prepare you for how you're going to be using it functionally after surgery. The last exercise is the knee extension stretch. If you're planning on having the hip surgery and you have the hip guide, this exercise won't even be in your book. This is just for the patients that are having the knee replacement. So in that photo, they have the person with their leg propped up, a roll underneath, and the main thing is we call it a dangled position. So right under here, this is non-supported. And what I usually tell people is I want them to have a cup of coffee, something that they can sit and relax, because for the next 15, 20 minutes, we want you nice and calm and in your happy place so gravity can do its magic and slowly stretch that muscle out. Now for me, I can sit like this. I don't have tight hamstrings because I don't have issues with my knees. People that are having the hip surgery tend to have been walking around like this. Okay? So here they have all this soft tissue tightness right back here. So I know Hannah talked about when you're in the hospital, the nurses are trained not to put pillows under the knees. So when you're in bed, they're not going to be putting pillows underneath that knee, so you can feel where that's stretching out. The main thing with this is the surgeon said we don't want pillows back there because you develop the contracture. On the next slide, I'm going to talk about it. I still will come back to this, but on the next slide, I talk about the goals. And people having a knee surgery, they think, oh, I got to bend my knee, I got to bend my knee, I got to bend my knee. The first thing on that goal slide is they talk about having a 90-degree angle of the knee. That's our goal here in the hospital. You'll be working farther in outpatient and home health to get it farther, but that's our goal here. What people don't think about is we want that knee to go absolutely straight. So one of the surgeon's first goal is that leg goes to 0. The reason being for this is for us to walk normally is when I step, look at how straight that knee needs to be. Okay? So this is actually one of the surgeon's first goals because we want you to start walking normally. Okay? So we want you after surgery that you're going to be walking like this. So when people see you, they go, wow, you had a surgery? Instead of, oh my gosh, you had a surgery. So we want to get that leg nice and straight. So that should cover all of our exercises. Don't worry, we only have a few more slides to go through. Oh, I didn't mention is we talked about on the gold slide that we want to get the knee to 0 and to bend to 90 for people having the knee replacement. For both people having the knee replacement and the people having hip surgery, our goal is that you walk 300 feet or more. Usually you guys do extremely well with that. Okay. Now we come to our discharge home. We have you riding in the front seat with that. Again, remember, initially you can't drive. You have to wait for your surgeon's release to be able to drive. So we have a loved one picking you up. We recommend that you're in the front passenger seat. The reason being with that is they can push the seat all the way back and then also tilt that seat back so you have more room getting in and out of that car. We recommend that you stop along the way. They say 2 hours on the sheet. Usually you'll become uncomfortable before the 2 hours. You want to keep moving, keep mobile with that. So on the next slide it says caring for yourself at home. This change positions often. That kind of goes with keeping moving. We want to keep the circulation going. We don't want you to get a blood clot. So we want to keep the circulation going for the health, keep some of that swelling down, keep those muscles nice and limber, and keep the pain down. Follow joint precautions. Again, don't worry, we'll be talking about that when you're here at the hospital. Walking daily and steadily, increasing your distance. Walking is a wonderful weight-bearing exercise, and we want that weight-bearing with the prosthesis. The surgeon probably showed you that metal portion that goes into the bone when they do the surgery. It has these roughened edges. So we want that bone to grow into those roughened edges to increase and enhance the stability of that joint. So that's why we want you walking to encourage that bone growth into that. That being said, too much of a good thing is not a good thing. We don't want you pounding on that leg. So it mentions in that slide to limit stair use. I don't like to say limit because of the fact that if you need to do stairs to get around the house, you need to do stairs. So what we do is we teach you that protected method. So you'll see that we're going up one step at a time, okay, and then coming down one step at a time. So you're not going one step after the other, which is kind of a pounding thing. Some people might hear up with the good, down with the bad, and again, we'll cover that when you're here at the hospital. Notify the doctor of fever, incisional redness, drainage, odor, or increased pain. This is where I look at you and say, you're having surgery, so you're going to have some pain and swelling. We don't want you to have a lot of pain, so that's where we have the medications, and we encourage you to have good conversations with the nursing staff. I like to bring up this scenario so you think about that while you're in the hospital. Is in the morning, I'll come in to talk with the nursing staff, see who I'm going to see for the individual therapy. So the nurse tells me, Mrs. Jones is doing awesome. She just finished her breakfast. She's sitting in the recliner with her cold pack on, and she's declining pain medicine. She said she doesn't need them. Awesome. I'm going to go start with Mrs. Johnson. We go in, we get the stuff all out of the way, we take the cold pack off. Mrs. Johnson starts to move that leg, and she goes, oh, that's more sore than I thought. So when you're talking to the nursing staff about taking pain medicine, they'll tell you to rate your pain, and Hannah talked about rating pain. What I want you to talk to them about is not what your pain is just sitting there with the cold pack on. Also share with them, what is that pain when you're moving? Because we're going to have you moving, and we keep you moving quite a bit while you're here at the hospital. We only have you for a day or two, so we keep you really busy. So I think that's it for my slides. Hannah will be finishing off a little bit. If you have any questions, please look in the guidebook. There's a lot of information in there. If you're not finding your answer, I believe Hannah gave you her contact information. Please call Hannah. She can help you out. If she's got any questions that she needs to contact me, she can reach out to me, and either she or I will get back to you with an answer as soon as possible. I know it's a lot of information. I appreciate your patience and staying with me on all of this. Good luck. Best wishes for your upcoming surgery, and we're really looking forward to seeing you soon. Thank you.
Well, thank you for watching. I know that was a lot of information to take in. You can rewatch this at any time. Feel free to call me if you have any questions or concerns. My number is on the screen. My contact number is in your guidebook. Some things I want to share with you, some pearls of recovery. To wrap this up, pick a day each week, measure your progress. You're going to have good days, bad days, better days than others. If you reflect back on the week as a whole, you'll see how you progressed. Do your exercises regularly. Eat healthy and don't smoke. Smoking prevents healing and causes other bad things. Again, thank you for watching, and thank you for choosing us.